My name is Shahzad Shamim. I am the Chief of Services at AKUH Hospital for Neurology, Neurosurgery, and Psychiatry Services. And I'll be talking about neurosurgical intervention in stroke. The roadmap for today's presentation is we'll talk about both the supratentorial strokes, including hemorrhagic and ischemic strokes, and infratentorial strokes in both hemorrhagic and ischemic. This is primarily about spontaneous hypertensive hemorrhages and does not cover mechanical thrombectomy, subarachnoid hemorrhage, stroke due to AV malformations or vascular lesions, because most of these topics have been covered by other speakers in the meeting. Moya disease or stroke prevention, including endarterectomies or angioplasties. So the fundamental principle for stroke management is basically is best illustrated by this slide here, where you can see the two different types of brain. On the right hand side is a young patient with a full brain on the CT scan, and on the left hand side is an elderly patient with lots of CSF spaces, lots of potential spaces to accommodate large volume of brain edema or hemorrhages. And this has been the reason why there are no guidelines in terms of, or rigid guidelines in terms of what size of hematoma is best evacuated and what size is best left alone, or what degree of infarct should need surgery and what doesn't. Because at the end of the day, the indication for surgery in acute stroke for supratentorial strokes is raised intracranial pressure, which is refractory to best medical management. And so not every patient will need surgery. It's only a patient with raised ICP where the ICP cannot be managed despite best medical management. And the key word here is the best medical management, which we often don't offer before we offer surgery. For infratentorial strokes, the indications are different, and it's usually the brainstem compression or hydrocephalus which warrants surgery, and not the ICP, because ICP tends to rise late in cerebellar strokes. So if you ask me to talk about this topic in just one slide, this will be my slide. That the role of neurosurgery in acute stroke is basically restricted to these two fundamental principles. So we'll start with the supratentorial hemorrhagic strokes. And we would have thought that the STICH trial would, after more than 1,000 randomized patients, 87 centers, 85 centers, 27 countries, would give you a definitive answer on which patients get better with surgery or which don't. Although in the trial's defense, the trial never ventured to answer the question whether surgery was beneficial or not. It basically was to look at early surgery versus initial conservative management, even though the outcome of surgery did come out as a very valuable secondary outcome of this trial. And if we've learned something from this trial is that evidence does not always help. Firstly, the trial was inconclusive in terms of whether surgery really does help these patients. I shouldn't say inconclusive, it was suggestive that it really doesn't. And even despite such a big trial, the rate of surgery for ICH did not change in most European countries or North American countries. And in fact, there are massive variations across the globe for rates of surgeries for ICH patients. Even in the same countries, there are massive variations within different cities and in different hospitals. Although one good thing that did come out of the STICH trial was the STICH-2 trial, because a small subgroup of patients in the STICH-1 trial with lobar hemorrhages did tend to show some benefit from surgery. However, like all, so there is one center where the STICH trial actually did reduce the rates of surgery. Interestingly, it's the same center where the STICH trial was conceptualized and conceived, and David Mendelow was the principal investigator for both STICH-1 and STICH-2 trials. And in his center, the rates of surgery did go down. So that sort of tells you, even now, after so much research, the role of surgery remains differently thought of across the globe. And even STICH-2 trial, which carried a lot of fanfare with it, did not convincingly improve the role of surgery, even for lobar hemorrhages. Although in our practice, we routinely offer surgical management for lobar hemorrhages. Firstly, the surgery is very low risk. And in our experience, the results are very good. However, we do not have a control group, so we can't say whether these patients would have done well even without surgery to begin with. So we give a benefit of doubt to these patients, as I said, because the risk of surgery are minimal, and it's quick surgery, good, low risk, and apparently good results. One thing that has really helped us in deciding which patients should not go for surgery is the Hempel's ICH score. And even though this was introduced before the STICH trial, it still remains the number one resource. So you get a call in the middle of the night by a very eager neurology resident or a neurosurgery resident who feels that this patient has a very large hematoma that needs evacuation. And normally you would give it the benefit of doubt to the patient and take this patient to the OR, evacuate the clot, hoping that you can pull off a miracle. But this ICH score is something which has really humbled the neurosurgeons and neurologists all over the world, and clearly, even though the numbers aren't that big in the initial paper, it has been validated, and our experience has been the same. And it sort of tells you which patients will not get better with surgery, so they automatically help in the decision making, and also to convince the families, where in our culture tend to be very persuasive towards intervention when there's no hope that is visible to their loved one, for their loved ones. There's a lot of talk about different treatment options for these patients, including putting an ICP board and monitoring ICP, putting an external ventricular drain, which is more commonly done for intraventricular hemorrhages, although I must tell you it does not work. And we'll talk about that. The standard tried and tested is doing a craniotomy and evacuating the clot. There's a lot of interest in endoscopic clot evacuations. There's an interest on direct or indirect thrombolysis of the clot using different drugs, and it's more commonly done for intraventricular clots, as we see in the mystery trial, or during a decompressive surgery. So there's no such thing as a minimally invasive surgical procedure for clot evacuation, because all of these are minimally invasive procedures, to be honest. So there's lots of literature on one or the other procedure, and lots of surgeons, including myself, have tried all of these. I've tried each one of them several times, and I can tell you still the best procedure is doing a standard craniotomy and evacuating the clot. So the more things change, the more they remain the same. And although the lots of trials and lots of studies have made professors out of lots of neurosurgeons and neurologists, patients still benefit from the procedure that we used to do 30 years ago and still do. And the results may look fantastic on the post-op CT scan, but again, we have to go back to the evidence in terms of what really helps our patients and what doesn't. And this is especially true for intraventricular hemorrhages, where there's a lot of interest in putting a drain and trying to take care of the hydrocephalus. So I can tell you that putting a drain in the hopes that the clot can be evacuated does not work. The mystery trial shows that the drain only works for hydrocephalus, but when there's blood inside the ventricles, the drain just keeps getting blocked. So our indications for intraventricular hemorrhage in terms of surgical procedure is only to put in a drain in when there's life-threatening hydrocephalus. Again, our experience is that after a while, the clot sort of stops expanding in size, and even though there is hydrocephalus on the scan, it does not progress. So most of these patients will not require any surgeries, whether it's evacuating the clot or putting a drain in. So you just have to be patient. And when there is a doubt, you can just put in a board and monitor ICP. So the summary of evidence, ICH evacuation may benefit a small proportion of highly selective patients, perhaps with lobar hemorrhages. For non-lobar hemorrhages, surgery may improve survival, but it does not improve functional outcome. And again, survival benefit is also a matter of question, and we have to go back to the ICH score for that. Early surgery is not superior to initial conservative management, so whenever in doubt, wait and watch. Choice of procedure does not impact outcome. Ischemic stroke, there's a lot more literature, agreed upon literature available, and lots of romantic sounding trials available, Destiny, Decimal, HAMLET, But what they all of us do show us is that young patients with full territory infarcts may benefit from decompressive craniotomy. Again, the reason for surgery is intractable ICP. It may improve survival, does not improve functional outcome, and surgery indicated only when raised ICP is refractory to best medical management. As I showed you in the first scan, the first slide, young patients with fuller brains are more likely to require surgery because the edema created by the infarct is increases ICP to dangerous levels, and that may cause secondary injury to other parts of the brain. But this surgery is, again, not without complications. So even though it's the simpler surgical procedure, we do not fiddle with the brain. We just take the bone flap off, do an expansile uroplasty. But these are sick patients. I mean, when they go under general anesthesia, the risk worsens, and they may end up in ventilator and require tracheostomy. So we very rarely offer this surgery for dominant hemisphere infarcts because the outcome is generally so poor despite surgery. And even though the surgical procedure is quick, it has to be supplemented by a cranioplasty, wherein we put in the bone flap back on. And again, it may sound like a very simple operation, but because of the particular risk factors in these patient subgroups, the procedure has been reported to have almost 25% risk of complications all over the world. And we published extensively on our own results. Our results are comparable to few of the best centers in the world on it, but still the inherent risk of this procedure are very high. So what about infratentorial hemorrhagic stroke? So cerebellar hematomas. So just a point that I'd like to make about lobar hemorrhages: whenever you see a lobar hemorrhage, do suspect a secondary cause, and so a non-hypertensive reason for the hemorrhage, whether it's a vascular malformation or an intralesional bleed, and do push your surgeon to send tissue for biopsy whenever there's doubt. So the reason for intervention in cerebellar hemorrhages and stroke is different from supratentorial stroke. Here, the problem is not ICP, but brainstem compression, as you can see in this scan, and hydrocephalus. And also, these patients tend to do really, really well unless the brainstem is involved. These patients tend to have a very good outcome with rehabilitation and time. So the tendency should be to be more aggressive in these patients as compared to patients with full territory infarcts or IC infarcts. And surgical options include evacuating the clot, doing a decompressive surgery. The image you see here, it's the wrong image. We usually do a bony decompression, which extends from the mastoid all the way to the midline or even across the midline, and then do an expansile uroplasty to make sure that there's enough space for the cerebellum to expand and allow decompression of the fourth ventricle or the brainstem, and evacuate the clot whenever it's possible. And we did our own review of cases. So our results also showed, and this is based on 79 patients, which makes it one of the largest series in the world. A few factors which determined outcome was the size of the clot. The bigger the clot, the poorer the outcome. The poorer the GCS, the poorer the outcome. The more comorbids, the worse the outcome. But the patients who survive tend to have very good functional outcomes given enough time. Ischemic strokes is again the same principle. The reason for surgery is either hydrocephalus or pressure on the brainstem, and the goal of surgery is to decompress the brainstem and relieve the hydrocephalus. So compared to supratentorial strokes, the treatment options are more diverse for cerebellar strokes and hemorrhages. So you can either just put an ICP board, although I would not recommend it because in these cases, the ICP raises late after there's hydrocephalus or enough brainstem compression. So ICP monitoring isn't the ideal thing to do in these patients. If you are in doubt, put in an external ventricular drain where you can decompress the ventricles and also monitor the ICP. Connectome and clot evacuations are the best means to decompress the brainstem, although it's not always possible. And the reason is because these are sick patients, and compared to supratentorial surgery, these surgeries are more extensive, are more complex, and take longer time. They're done in prone position, so they're more inherent risk associated with anesthesia. So whenever you're considering a surgery in patients with cerebellar infarcts or strokes, ask yourself these three questions. Is there pressure on the fourth ventricle, or is there hydrocephalus? is there pressure on the brainstem? And can the patient tolerate a major surgical procedure? And based on this, you can decide which surgery to offer. If there's only a pressure on the fourth ventricle and hydrocephalus, you can get away with putting a drain in, which has a low risk of reverse cerebral reverse herniation. But it's a simple procedure, it takes 20 minutes and can save somebody's life. However, if there's pressure on the brainstem, you have to do a more elaborate procedure in decompressing the brainstem, although it all depends whether the patient is well enough to tolerate this surgical procedure. I have a few slides on CVST. I'll skip those, although I must just mention that CVST, when intervened early, tends to have a very good outcome because these are hemorrhagic infarcts and these are typically young patients, although they have to be anticoagulated right after surgery. So once again, my message is the indication for surgery in acute stroke in supratentorial stroke is to relieve the ICP only if it's refractory to best medical management. In cerebral stroke is to relieve the brainstem compression and hydrocephalus. Thank you very much.